you think that giving them treatment is ethically and also can prevent deterioration or improvement on the field you mentioned before?
Okay.
Thank you.
As a prophylactic. Okay, if you're talking about cognitive symptoms, cognitive impairment, isn't it?
Cognitive impairment for schizophrenic parent. Cognitive impairment for schizophrenic parent.
Parents?
Yes, father. Father schizophrenic or family has schizophrenia, and you have cognitive impairment for a child without signs of psychosis. You're saying that 98% possibility of schizophrenic later on. It means that I can give him medication now to try to abort process of schizophrenia?
No, what I'm saying is what I said is 98% of those who have schizophrenia don't reach the expected educational or cognitive state or level compared to their parents. That's the 98%.
This person, he is not a patient yet, but all his symptom is definite cognitive impairment with positive family history of schizophrenia.
With positive family history, okay,
Yes.
schizophrenia.
If I'm allowed to answer these questions, Dr. Gamal, I don't know why up till now we are afraid from applying the early intervention for treatment of psychosis, including the schizophrenia. It's evident now. If this patient this person have a first degree relative with schizophrenia, he is 10 times more than any person in the general population to develop schizophrenia. When we notice there is symptoms, differentiate this child from the normal children like cognitive impairment, yes, at this time we can start giving that medication, because at this time you can give a small dose that will protect him from going into the disease stage. If we apply the wait and see policy, which most of us usually use it, we can catch this patient while he is, or this person while he is definitely an ill person. And at that time you are chasing the disease, not preventing the disease.
I will definitely address this on my lecture about ethics with schizophrenia. And I will disagree completely with this. It's an opinion, but I will explain why I'm going to disagree with it from ethical perspective and medical perspective. However, what you are saying is actually talking it a lot. They are talking a lot about it. They call it high-risk group. They call it attenuated psychosis syndrome. It's a high-risk group of people without active psychotic symptoms. Do we treat or not? There is a huge ethical debate about it, and I will explain. I'll respond to that question on my presentation.
Then I contribute.
Attenuation means that we need to start in this. We have three groups for those you are going to deal with them with the early intervention. One of them is the attenuated psychosis, and one of them completely normal. All what you have is observation. Having the gene, having the birth complication, having deterioration at the school, having abnormal behavior. So collecting all of those symptoms together make them highly recommended to start the medication, even if they are not ill. And by the way, you discuss with the family and explain to them the future waiting for this person. If they are accepted to wait till the disease is already definite, yes, it's okay for them. If not, I have already cases now. I started with them in this pre-morbid stage. Okay?
Yeah, I would like just to add something. I tend to agree with yourself. The reason for that is, if we're talking about schizophrenia, I'm talking about cognitive impairment treatment as antipsychotic, well, the evidence is not huge. So there is some evidence, but the effect size is modest. That's one thing. The other thing is, and I don't know of any high-level evidence, I'm talking about meta-analysis or systematic review to support the the suggestion that we should treat it. I'm not saying that's right or wrong. What I'm saying is I'm not aware of any high-level evidence. So moving on. So that's how cognitive impairment affects activities of daily living, occupational functioning, social functioning, relationship, and everything else. Moving on. I think you know that. You know where the sites where attention is there, is process, problem solving, planning. That's mostly prefrontal, sensory perception, visual perception, learning and memory in the temporal. Okay, the role of neurotransmitters. Nearly all of neurotransmitters are involved or implicated. However, those are the main three: dopamine, glutamate, and acetylcholine. Say why? Well, it is complicated. It's genes of everything are implicated in schizophrenia. I'm sorry, not everything, but a lot of things. Like this binding, which is responsible for the physical bursting into the neurotransmitters, the neuroglin, those genes, the NMDA, the 5-HT, the metabolic non-NMDA glutamate receptors, the catechol-O-methyltransferase, and other things. So all of those genes are implicated in the development of cognitive impairment schizophrenia. Let's talk about dopamine. You know that we have 5 classes of 5 types of dopamine receptors, starting from D1, D2, D3, D4, D5. They are families. So there is family D1, D5, and there is the family of D2, D3, and D4. Antipsychotic or the antipsychotic effect of antipsychotic medication is mediated mainly through D2 blockage. However, the cognitive impairment is mediated somewhere else through a different receptor. So, in positive symptoms of schizophrenia, there is the mesolimbic system, the ventral tegmental area, and there is increased dopamine from the ventral tegmental area to nucleus accumbens, and that's where the positive symptoms happen. The problem is between the prefrontal and nucleus accumbens. It's hypodopaminergic state. There is less dopamine, and it's mediated mainly through D1 receptor. So anything that could block D1 receptors, so mainly D1 receptor, could have detrimental effect on cognition. Other enzymes are implicated related to dopamine. So catechol-O-methyltransferase is the enzyme that's responsible for catabolism, breaking down of dopamine in the cleft, in the synaptic cleft. And methylene transferase, methylene folate reductase is an enzyme implicated in folic acid, then dopamine metabolism, and it is implicated also in the cognitive impairment, and those are the pathways I mentioned. Okay, so what's happened to glutamate? I'm not going to talk a lot about glutamate because Dr. Karim is giving a lecture on glutamate, but for glutamate, it's high and low at the same time. So there is hyperfunction of some of the receptors, and there is hyperactivity in some systems. So I'll leave that to Dr. Karim to talk about glutamate.
Do we have D1 and D2? D1 and D2 are responsible for what in real practice, clinically? You know, the previous slides.
Oh, okay.
You're talking about D1 and D2.
Yes.
In real life, clinically, what do they give us, symptoms-wise, cognition-related?
D2 is positive symptoms.
Okay.
Okay. D1 is cognitive.
Right.
D2 is ventral tegmental area and nucleus accumbens. D1 is prefrontal.
So medication-wise, to get to the cognition, we need to play with the D1.
You need to increase the activity of D1, yes.
Yes.
What's your thought about the aripiprazole and the role of the dopamine agonist?
Okay.
And that's another theory of the aripiprazole.
The meta-analysis didn't show superiority of it. It was very inconsistent, because if we talk about, I'm going to talk about it in a minute. If we talk about global cognitive performance, it doesn't really affect it that much, okay? And some antipsychotics affect some cognitive domains in a different way and to a different degree. So in theory, it's great. So it's partial, dopamine agonist, antagonist, but it doesn't work.
Cognitive impairment, when we look at it in terms of the premorbid cognitive impairment and the results of the medication as a cognitive impairment, is there anything that we need to do or know about which is actually, whether it was from the beginning premorbidly and getting worse as the nature of the condition of the illness, or is it getting worse because of the medication it's making it worse?
Okay. Cognition tends to get worse around the first episode. Okay? It shouldn't continue to get worse. It should not continue to get worse. So it's not a progressive cognitive impairment. It's kind of plateau. After the first episodes, all of the damage happened around the first episode. But it's plateau. Okay. Where is it? So, yeah, that's again the trajectory of the cognitive impairment. Okay. You know that we are born with a huge amount of neurons. It's 100 billion neurons, and there is a lot of interaction between the neurons. And as we get older and as we learn, there is some pruning that happens, and the pruning is good. Loss of some connections is good. It's not bad, because if I have 100 ways to reach A, that's difficult. What learning does is any unnecessary pathways is deleted, eliminated, so I can reach from A to B quickly. So it's functional, that's good. This is a function of dopamine. The dopamine does that. I'm not talking more about dopamine. Sorry, not dopamine, glutamate. I'm sorry, I said dopamine, it's glutamate. That's a function of glutamate. I'm not going to talk again about glutamate because Dr. Karim is talking about it. And that's the genes again implicated in cognitive impairment. So the higher genetic load with defective genes causes more cognitive impairment in schizophrenia, and that's the list of the most of genes implicated so far. Okay, how can we assess cognitive impairment? We can ask questions to the patient or relatives, or interview-based measures of cognition. So not testing the cognition, but asking about the patient experience of cognitive impairment. So that's one thing. Or assessment of cognition with a bedside tests, or standardized neuropsychological testing with normative data, and challenging tests during neuroimaging. So doing cognitive challenge during MRI or PET scan. Okay, so I said that it's through informants, asking about cognitive symptoms through informants or the patient, or using one of those skills. So that these are interview-based measures. Schizophrenia cognitive rating scale, SOSA. It talks about 18 items, or clinical global impression of cognition in schizophrenia, which is 38 items. The bedside cognitive testing, there are a plethora of them, but the Arabic validated or the validated tests are limited. So adequate cognitive examination 3, Mini-Cog, Mini-Mental State 2, Cognitive Montreal, and RODAS. And apart from ACE3, the rest have been validated for old age.
So which one should we use as routine practice? Like for somebody, if we know they're going to have cognitive impairment, so we know that for sure. So when they come to us, should we use one as part of our assessment when we make a diagnosis?
Okay, if you're worried about cognitive impairment, I think you should assess that. If you want to treat cognitive impairment, you need to quantify it. Okay? The thing is, not all of the cognitive impairment or cognitive assessment tools are validated for this illness at this age.
The 18 item was the one you showed before.
In Arabic.
Okay.
In Arabic, if you are talking about assessing the patient experience and or the care experience of symptoms, that's the easy thing. If it's testing, you want to test the challenge to see how much cognitive impairment there is, you need to assess the cognition, not to ask about cognition. Okay. So those are the tests validated for your information. I'm just going to mention that one because I've been involved in validating it with my colleague and friend, Dr. Karim. We have validated it to Egyptian Arabic in 2015 and published the normative data for it. It asks for attention, memory, verbal fluency, language, visual spatial ability. The maximum score is 100. And the good part of it, it's sensitive for frontal impairment, because there is fluency part of it. Does it want to move?
I think we'll talk more about it.
It's stuck, I think. Yeah. And that's it. That's the Arabic version. We'll send you a handout or a printout of it. It's online also. You can download it from online. Now, do you want to talk more about ACE?
I mean, with ACE, let's say, should you use it as routine practice instead of the mental state?
ACE takes 15 minutes to do it. I recommend, if you have some time and it's more detailed.
I don't think anybody has the time, but if it has indication. You know, I remember I went to the Royal College meeting once. They used to have one track about, the neurology, and they said mini mental state examination is useless. The minimum should be ACE. They said you're wasting your time by doing mini mental.
Yes, because it's not subtle enough. It doesn't really pick a subtle cognitive impairment.
Anybody use ACE here? In Arabic or English?
This would me like half an hour to finish it with the
Really?
sometimes, yeah. Because I tried to translate, I didn't know there was an Arabic version.
It's online.
Properly.
It takes an hour for me in Arabic because it's Egyptian Arabic. No, it's not. Anybody else use ACE? I mean, I think one time we did a full day or full CME on ACE, so it might be something that we probably need to do around between Dubai, Abu Dhabi, and all of that with the journal clubs, is to get people to be familiar
There are
with it. Because I think
antibiotics
it gives you some information that, extra might help you to know whether it's going to be impairment or not.
Yeah, especially frontal, because we know that most of the cognitive impairment in schizophrenia is frontal.
I mean, my experience of using the ACE is that it's something that the more you use it, the quicker you do it, basically. Like Dr. Torres said, it's available in Arabic, Egyptian Arabic, so it is designed to be, the statements are written in common Egyptian language, because it is for an Egyptian population. I think there was a Saudi version of the old ACE from 2005. So that was adapted to a Saudi population. So there might be relevance to it. It might be relevance to using it in local UAE population. The only issue with the old ACE is that it incorporates the mini mental state examination, and as far as I'm aware, there's a copyright issue if you use the ACE-R, the old Adam Brooks. So just be careful. But it is available in a Saudi for a Saudi population, and it might be adaptable to an Emirati population as well.
Just that's the neuropsychological test available, validated in Arabic for your information. But pen and paper assessment tools are not the only tools. You have the computerized tools now. There's the standard touch screen assessment for cognition, and there's the CANTAB, which assesses attention, psychomotor speed, executive functions, and there's a demonstration of how the CANTAB works. That's the sorting test. To press. No. It's a video, but it's not. Yeah? Yeah. Can you just press on the space bar? Okay, so that's how the stopped. Yeah, that's how the test is performed. So the task of that test is to align them similarly, the upper and lower balls. And you have all of the tests mentioned, and that you could install that on an iPad. But it's not free, of course. Now, treatment. Talk about pharmacotherapy, whether antipsychotics or cognitive enhancers, repetitive non-invasive brain stimulation, physical activity, and cognitive remediation therapy. So we have quite a few targets in the brain that we can target our drugs to improve cognition. So the GABA, the glutamate, nucleoside which is acetylcholine, and dopamine, of course. Now, the antipsychotics, first generation antipsychotics, they show some effect, positive effect when we treat patients with cognitive impairment, but the effect size is small. It's not great. So they are effective. The second generation antipsychotics, initially, they showed an edge over the first generation. However, more recent meta-analysis failed to produce consistent finding, and failed to produce consistent finding between every new generation or second generation antipsychotic, because every molecule has different receptor profile. The drugs that are under development now are mostly D1D5 agonists, and there's the DAR 100 or the dihydroxyzidine, which has shown some positive results in RCTs, and they're still under development. The thing that I thought would work, or the thing that I thought that I would find evidence for, is catechol-omega transferase inhibitors, which are used a lot in Parkinsonism. I thought that I would find some evidence for use in schizophrenia. I couldn't find hardly any except with that one, which is 10 years ago. I don't know why. It makes theoretical sense, but I don't know why they are not used.
You say no evidence. Do you mean no trials or no
I couldn't find any randomized controlled trials. I couldn't find that. And I thought I would find more. I couldn't. And I don't know why, because this class of drugs are fairly safe. They're not that dangerous drugs. But I don't know why they're not used, or at least why there is no research into them. Modafinil, the smart drug, I don't know if you know modafinil. People call it a true smart drug because it enhances cognition even in normal population. But in schizophrenia, there was no effect. Talk about it just a minute. Okay? Oh, that's. In psychiatry, we have two major cognitive disorders. We have schizophrenia at the end of the life, and we have ADHD developmentally. So the thought was to try to use the drugs treated for dementia at the end of the life. Dementia is the prototype of cognitive disorder at the end of the life. So we thought about using drugs for Alzheimer's disease to treat cognitive impairment in schizophrenia, and donepezil and rivastigmine did not show any effects on cognitive impairment. However, galantamine showed several benefits on attention, delayed memory, visual recognition, processing speed, and verbal memory. And the thing is, among the three, donepezil, rivastigmine, and galantamine, galantamine is the only one that has nicotine agonist effects.
So are we talking about using them in those studies very late? Or are we using it with first episode psychosis, early treatment?
If you have concerns about, first, there is no...
The study. Those one, what
The studies examined the effect of galantamine on several cognitive parameters. Okay? So when you co-administrate galantamine along with antipsychotics, you find positive effects on those parameters.
Because if we can compare it with dementia, usually you use them early to stop the decline.
Yeah.
So if we're going to use that with schizophrenia, then it makes sense I use it before the early decline you showed us. I use it as a preventative rather than improving cognition.
Okay. It makes logical thought, okay?
What?
But I don't know if there is evidence or not. A lot of the things that we talk about that makes logical sense sometimes work, sometimes don't work, but it's a safe drug. The problem is it's affected a lot with smoking. So the level goes down with smoking.
So when it goes down?
Galantamine.
But for some studies, nicotine reduces the doses of, for example, clozapine and olanzapine. So that will improve the cognition, but will increase the positive symptoms? Like glutamine?
No, I'm talking about galantamine. Galantamine has no relation with positive symptoms. Galantamine is an anti-dementia medication.
But if smoking affects the level of, so smoking will affect also the antipsychotic level. So it might be a deterioration on the positive symptoms.
I think let's talk about, for example, clozapine. Clozapine is affected a lot. Okay, if a person doesn't smoke and suddenly they started smoking again or pick up smoking again, we know that then we need to increase the dose of clozapine. So I think the same goes for every drug. That's the answer to your question. Yes, it does. Whether smoking, not advocating smoking, or whether giving it nasal, spray, gum, or patch.
That's why most of schizophrenic patients are smokers.
Okay, so there are RCTs to support use of gum or patch for cognitive impairment in schizophrenia. But I'm not comfortable, if I'm a clinician, I'm not comfortable doing that. Hello?
We'll do it for you.
Memantine also works. And works, yeah, there is a difference of minimum state examination, that's the trial, of 3 points out of 30, which is impressive. And the thing is, when you combine it with galantamine, the effect size is bigger. Atomoxetine did not work. Guanfacine, which is another drug used for ADHD, well, there is some effect, but not huge, on spatial working memory. But the effect is not huge, and that's one study. So very, very weak evidence to support this theory. Antidepressants, the pooled analysis of trials of antidepressants in cognitive impairment, yes, the effect is statistically significant, but not clinically meaningful. So it's half of a measure of 100, which is nothing. If you are using it for cognitive impairment, not for depression, of course. Yeah, and the effect is mostly for SSRIs or serotonergic drugs. Okay, cognitive remediation therapy. it works, and the effect size is not bad at all. That's medium. Cognitive remediation therapy is cognitive training, the games that are designed to stimulate cognition. It's like brain exercise, and they work. And not just they work, when we study them under the functional MRI, they hit specific areas of the brain that are responsible for cognitive impairment. And so we start seeing some improvement in those areas.
Excuse me.
Yes?
Hi. Is there any correlation between the type of neuropsychological impairment and symptomatology? Because in the past, some theorists have postulated that delusions could, for example, represent a dysfunctional semantic memory system. So is there more emerging evidence linking the type of neuropsychological impairment and symptomatology?
Okay. Most of the evidence are that cognitive impairment correlates weakly with positive symptoms all through. Okay. There may be neurophysiological correlation, but not as cognitive impairment. Physical exercise also works, especially aerobic physical exercise. And it works mostly with the working memory, social cognition, and attention. And it works mostly if the physical exercise is prescribed. And for example, in the UK, my background is from the UK, so in the UK, GPs, general practitioners, can prescribe physical exercise to their patients. They do it. Physical exercise seems to exert its effect through enhancing the brain-derived neurotrophic factor, the chemical in the brain that stimulates neurogenesis. And what works even better is the combination of two: cognitive training and physical exercise. Physical exercise, what physical exercise does, it increases the level of neurogenesis. So before exercise, we had 4 cells, for example. During exercise, there is multiplication. But unfortunately, when you stop exercise, those generated cells die away. So that's how physical exercise works. It's rate of neurogenesis, but the rate of those cells die away. Mental training works in a different way. It reduces the rate of cell death. So if you continue training your brain, you will increase the lifespan of the neurons. The best thing is to combine two, is to combine physical exercise and mental training, so you have more cells generated here, and those that have been generated last. I don't know where that. Yeah, I know. Have you heard of brain hacking or neurohacking? Have you heard? Okay, neurohacking is DIY devices designed to stimulate your brain electrically. Gamers claim that it works. It's consumer-based devices. They are sold, by the way. Consumer-based devices for electrical stimulation of the brain. And that's, what they overclock your brain, like overclock your CPU. So, unfortunately, stimulation of the brain